Now, this about the pectoral girdle. Now we have discussed what a pectoral girdle is before. Pectoral girdle is what connects the upper limb to the axial skeleton. You know what is axial skeleton now very well. So when it comes to pectoral girdle, there are two bones forming the pectoral girdle, the scapula and the clavicle. These are the two bones that form the pectoral girdle, and the upper limb is attached to the pectoral girdle through the shoulder joint between the humerus, head of the humerus, and the glenoid cavity of the scapula. Now, this the pectoral girdle is the only place where the pectoral girdle is connected to the axial skeleton through a joint is this joint. It is the sternoclavicular joint. So that is the only joint that connects the pectoral girdle bearing the upper limb to the axial skeleton. It is called sternoclavicular joint. Then it's unimaginable, with that amount of weight in the upper limb, having only one small joint here, connecting the whole thing to the axial skeleton through that joint. So the reason, why it can be maintained, how it can be maintained, is that there are so many muscles attached all around the pectoral girdle, keeping it in place, even though there is only one place where it physically attaches to the axial skeleton through the joint. So you can see this muscle, which is called sternocleidomastoid. You will learn these muscles later. Then the trapezius there. Then if you go behind, this is the trapezium again. Then you have these muscles deep to the trapezius muscle. You have these muscles. Okay, levator scapulae, rhomboids, and all that. Then there are certain other muscles that you cannot see from this side. They are deep here. So there are so many muscles that attach and even these muscles like pectoralis minor muscle here, even pectoralis major muscle here. So all these muscles attach the pectoral girdle with the upper limb to the axial skeleton. So because of that reason, contraction of these groups of muscles can move the pectoral girdle together with the upper limb. As a whole, the whole set moves. So that actually increases the reachability. So you can reach something distant from you by moving not only the upper limb joints, but also the scapula. That's why, these terms, rotation of the scapula, elevation, depression, protraction, and retraction. So all these movements are possible. Protraction means you move it forwards. Retraction means backwards. Then elevation, upwards, downwards. And of course, you can have rotation, external rotation and internal rotation, where this lower angle will move outwards or inwards. So all these movements are possible in the scapula. Actually, I forgot to summarize it in a slide, scapular movements, which I should have done. But just remember, all these movements are possible in the scapula because it's attached only in one place. So it increases your reach for the outside world. So that with that, if you look at the clavicle first as a bone, you can see the labels. I have shown you two images. If you have the bones with you by now, it would be very easy. You can take the bone into your hand and follow the lecture with the bone in your hand. That would be the best way to do it. So you do the practical also at the same time, which is very useful. Now then, if you look at the bone, if you have one clavicle, you can look at on one side there is a superior surface. One surface is smooth, and other surface is relatively rough. So this relatively rough surface is inferior surface. That is this part. Relatively rough surface is inferior surface. Smooth surface is superior surface. So that is one point. Then the other thing is, if you look from the two sides, from these two sides, the medial end, this is the medial end. Medial end is wide and rounded. And if you look at the other end, this is your eye. Okay. If you look from that side, the lateral end is flat. Okay. So you can easily identify, you can recognize the medial end. You can differentiate the medial end from the lateral end based on that. And you can differentiate between superior surface and inferior surface because the superior surface is relatively smooth. Then the other point is, now this is right clavicle, of course, this is right clavicle. And now why I say that is right clavicle, when you keep it in place, right clavicle, medial end to the medial side and superior surface to the superior side, then the medial 2/3, roughly, somewhere here, medial 2/3 of the bone is convex to the anterior side. Okay, it is convex. So this is convex to the anterior side. You know what is convex. So with these things, you can say specifically this is right clavicle. So any bone, for that matter, any bone, whether it's clavicle or any other bone, humerus, radius, ulna, any bone in the body, if you are given a bone, and if someone asks you to tell whether it's right side, whether it belongs to the right side of the body or left side of the body, so you have to look for this. You have to look for three directions. One direction is the structures that are related to three directions. That's how you put it. You have to look for medial lateral direction. That is one direction. So if you can find a structure that is on the medial side, then that is settled. Okay, or you can find a structure on the lateral side, that this structure is on the lateral side of this bone, you can say that, then that will settle the medial lateral direction. Only one is enough. Then the other direction is a superior inferior direction. Okay, so if you say that superior surface is smooth in this bone or inferior surface is rough, one is enough. Then you know which one is superior and which one is inferior. Then what you're left with is the third direction, that is anterior posterior direction. So that's why I said the medial 2/3 is convex to the anterior side. So with these three things, you can say this is specifically right clavicle or left clavicle if you get the left clavicle. Same rule can be applied to any other bone in the body. The only difference is if you take a long bone like humerus, rather than superior and inferior, of course you can use that also. Thinking of the anatomical position, you can say superior and inferior, but rather we use, instead of superior, we use proximal. You know, proximal and distal. So then the third direction would be, rather than superior and inferior, proximal and distal. So you have to tell some structures which are proximal or distal. So then you can say whether it's left humerus or right humerus. Then this I already mentioned. Then this also I already mentioned. Medial end is rounded and wide, lateral end is flat. Then because of this, flattening laterally, if you, I mean, this is not a main point, but not only superior and inferior surfaces you have, that of course you have throughout from medial to lateral end of the bone, there's a superior surface and an inferior surface. But people tend to call medially, this part, people tend to call it an anterior surface. And this part, this side, posterior surface, because the bone is wide there. So you see a surface. But here, when it comes to the lateral end, you rather call it a border. So there you have an anterior border and a posterior border. Even if you get mixed up with the border and the surface, it doesn't matter much. Okay, that's not very important. Then the other important point here is that you have two joints here. You have the sternoclavicular joint, only joint that connects the pectoral girdle to the axial skeleton. Then on the other end, you have the acromioclavicular joint. So that is the joint within the pectoral girdle which connects the clavicle to the scapula. Okay, that is the acromioclavicular joint. Now, both these joints are atypical synovial joints. Both these joints are atypical synovial joints. We have discussed the joints before and we have given these two under our examples. We might have to revisit when we go on with the lecture. Then there are several muscles and ligaments and some fasciae attached to this bone. I used to show diagrams showing all the structures attached to the clavicle. I don't know whether I can do that during this lecture series because you don't have a good idea about the muscles yet. So it would be just, a waste of time if I put that slide. So I removed the slide. Okay, so we'll take it up later if we have time. Then about the sternoclavicular joint, the medial end joint, we said it's an atypical synovial joint. And why is it atypical? For several reasons. Because there is fibrocartilage disc covering the articular surface rather than the hyaline cartilage disc. So that's the That is the case with the atypical joints. So you have fibrocartilage on either side. Then add to it, you have a fibrocartilage disc, which is called articular disc. So you have a fibrocartilage disc separating the joint cavity into two compartments. Then the other difference here is that you have a third structure contributing to the joint. Other than the manubrium and the medial end of the clavicle, you have the first costal cartilage contributing in the lower end to form the joint. So I said the joints are between two bones or more bones. Okay, so this is actually, even though it's not a bone, it's a third structure that contributes to form the joint. Then there's another point actually you can see here. You can see now these two ligaments, I was not going to mention here. You can see this is sternoclavicular ligament and this is costoclavicular ligament. So the sternoclavicular ligament is between the manubrium and the medial end of the clavicle. Costoclavicular ligament is between the first costal cartilage and the medial inferior surface of the medial end of the clavicle. So these are another two structures that attach the pectoral girdle to the axial skeleton, other than the muscles. Okay, so two ligaments. This ligament, of course, will form an impression on the inferior surface. I'll show you in the next slide. Okay, now this is the inferior surface of the clavicle. In the inferior surface, we said the inferior surface is rough compared to the superior surface. Now, in the inferior surface, you can identify three important areas. First one, on the medial side, if I start from the sternal end or the medial end, there is a tuberosity for the costoclavicular ligament. So that is this ligament, okay, costoclavicular ligament. So you can see that the tuberosity on the medial end on the inferior surface. Then there is a groove. Now in this bone, the groove is not very clear. It's here. So in the video, you can see the groove much more clearly. So this groove is for the subclavius muscle. There's a very small muscle called subclavius muscle. So for that muscle to get attached, there is a groove on the inferior surface of the bone. Then the third one, towards the lateral end, is the conoid tubercle. Conoid tubercle is the place where an important ligament is attached, which is called coracoclavicular ligament. Coracoclavicular ligament. Why is it called coracoclavicular ligament? It is attached between the conoid tubercle of the clavicle on one side, that is here, and the other end, it is attached to the coracoid process of scapula. Okay, when we do the scapula, you will see there's a process called coracoid process of scapula. So this ligament, coracoclavicular ligament, is a ligament attached between the scapula and the clavicle. Then at this end, it is acromioclavicular joint. Now in this end, you saw a sternoclavicular ligament attached here, then costoclavicular ligament attached here. Here you get acromioclavicular ligament attached. Now we will discuss about details about ligaments. What a ligament in one of the future lectures, maybe the lecture after the next lecture. Okay. Then the other point is that in the clavicle, since the bone gets flattened laterally, here this arrow, white arrow, area indicated by the white arrow, which is roughly the junction between the medial 2/3 and the lateral third, is the weakest point in the bone. That is the weakest area of this area is the weakest area of the bone, which happens to be just medial to the coracoclavicular ligament attachment to the conoid tubercle. Okay, we said coracoclavicular ligament is attached here. So that's a very strong ligament. It's actually stronger than the bone itself. So if there are forces, some strong forces transmitted through the bone, and if something is going to break, it is not the ligament here that breaks, but the bone itself. Okay, because the ligament is stronger than the weakest point of the bone. Some of these points may be little too much for you, but I will just mention it because we are discussing the bone here. Why I mentioned it was that the clavicular fracture is the commonest fracture in the body. Okay, for that reason I mentioned it, and it is more common in children than in adults. And it's most of the time it's due to falling on the outstretched hand. Now, what do you mean by falling on the outstretched hand is that when you fall to protect yourself, head and upper area, you tend to stretch your hand, open up your palm and hit the ground with the palm rather than the head or the trunk. So that's the natural reflex. So with that, the sudden forces that are transmitted through the upper limb can get transmitted to the clavicle here, and it can break. And it's not only the clavicle that breaks due to falling on the outstretched hand. If you read about fractures of the upper limb, almost all the fractures of the upper limb, one reason could be falling on the outstretched hand. So when a person falls like this, not only the clavicle, any other bone on the line can break. On the line can break, but you don't get too many bones breaking. It's usually in one place the forces are relieved. Okay, so rarely you can get more than one place broken. Okay, then you can fall on the shoulder itself and break the clavicle, or if someone hits you on the shoulder with a hard object or during a road traffic accident, this can break. You don't have to know a list of these things. Okay, so it's not so important. Okay, we'll go through the video now.
This is right clavicle, anterior, posterior, medial, and lateral. Therefore, this is the medial end or the sternal end of the clavicle. This is the lateral or the acromial end of the clavicle. This is the superior surface, and the superior surface is smooth. The medial 2/3 of the clavicle is convex to the anterior side. If you look at the medial end or the sternal end, it's rounded and wide. The lateral end, on the other hand, is flat. Medial half has an anterior surface and a posterior surface, and the lateral half has an anterior border and a posterior border. This is the inferior surface. Inferior surface is rough compared to the superior surface because of attachment of a muscle and two ligaments. Here, you can see the tuberosity for costoclavicular ligament. This area is the groove for subclavius muscle. This is conoid tubercle. Corpoclavicular ligament is attached to the conoid tubercle. Corpoclavicular ligament is a very strong ligament. It is stronger than the bone itself. When there's a sudden force applied to the bone rather than the ligament breaks. And when the bone breaks, usually it is at the junction between the middle 1/3 and the lateral 1/3 here, which is just medial to the attachment of the corpoclavicular ligament.
Okay, then about the scapula. Now the scapula is a flat triangular shaped bone, and you can identify many labels here, but I will try to take one by one. Now it has a medial border. Now this is the medial or the vertebral, because that is more closer to the vertebral column. Medial or the vertebral border, and this is lateral border. So you can see the glenoid cavity on the lateral side. That's how you identify it. Then you have a superior border here. Then you have an inferior angle, a superior angle, and a lateral angle. So there are three borders and three angles. Then you have an anterior surface here and a posterior surface divided into two areas by what is called spine here. Okay. Then at the lateral angle, you can identify this one, glenoid cavity or the glenoid fossa at the lateral angle. Then this anterior surface, there is a fossa for attachment of a muscle, which is called subscapular fossa. Subscapularis muscle is attached to the subscapular fossa. Then on the posterior surface, which is divided into an upper and lower part, the upper part above the spine of the scapula is called the supraspinous fossa. Supraspinatus muscle is attached to there. Then One below is called infraspinous fossa. Infraspinatus muscle is attached there. Then you have the spine starting from the vertebral end, going towards the lateral side. At the lateral end, it becomes the acromion. Acromion, this is the one that articulates with the scapula, forming the clavicle, forming the acromioclavicular joint there. So then, these are the main, and then there's another point, you have what is called scapular notch here. Then you have the coracoid process. So this coracoid process is the one that is attached to the conoid tubercle of the clavicle through the coracoclavicular ligament. So there's a ligament called coracoclavicular ligament. Not there actually, it's from here because the clavicle is here. Okay, so it's attached to the clavicle. It's a very firm ligament. So then this scapular notch, later when you do further studies, you will see there's a ligament here. Then under that, you get a nerve coming in to supply some of these muscles. And then you get an artery passing over it. Okay, those things you will learn later. Okay. Then the scapula, if you locate the extent of the scapula on the body, now since this is the posterior surface, if your body is here, if you check if this is the vertebral column, this level is actually the second rib level, the superior angle level, and the inferior angle level is actually the seventh rib level. Okay, second and seventh rib. That is the vertical extent of the scapula is from the second to the seventh rib. That can change if it moves up or down, but in the neutral position, it's between these two. So it extends from the second to the seventh rib. Then if you look at this carefully, you can see that some muscles like trapezius muscle attaches it to the axial skeleton. Now, if you remove the trapezius muscle, you see another set of muscles underneath that. On the right side, you can see you have levator scapular muscle, then there's rhomboid muscles, there's rhomboid minor and rhomboid major muscles. And there is another muscle called serratus anterior muscle, which is attached to this border of the scapula from the other side, anterior side. So all these muscles actually attaches the pectoral girdle, mainly the scapula, to the axial skeleton. Then on the anterior side, you have the sternocleidomastoid attached to the clavicle, medial end of the clavicle. Then there are other muscles like these muscles, which you can see here. These muscles are attached between the pectoral girdle, mainly the scapula again, and the upper limb. So what they will do is they will do a relative movement between the upper limb and the pectoral girdle. Okay, these muscles which attach to the axilla will move the pectoral girdle and the upper limb as a whole. Okay, I told you at the beginning, the first slide. Then the glenoid cavity of the scapula, it is a very shallow cavity. If you compare it with the hip, the acetabulum, which we will learn in the next lecture, acetabulum is the cavity related to the hip joint. Compared to the acetabulum of the hip joint, the glenoid cavity is very shallow. For that reason, it is sometimes not called cavity, but called fossa. Fossa is something shallow, not like a cavity. Okay, you call it glenoid fossa also. And but to deepen it further, there is a fibrocartilage rim around the glenoid cavity, which is called glenoid labrum. That deepens the cavity to some extent, but that is not enough. Shoulder joint is anyway a fairly common joint to get dislocated. In certain people, you get habitual dislocation. So as a habit, it dislocates. Habitual dislocation of the shoulder joint. So once it dislocates, then the ligaments get torn or weak, then it dislocates again. But you can see that all around there are muscles attached. Can you see muscles? Many muscles attached all around like a cuff. And there are many ligaments also attached. So these muscles, the muscles attached around it, together you call it rotator cuff. You will learn it later. I'm not going to highlight rotator cuff here. Only point that you can learn here is that it is reinforced above here, very well reinforced. You can see you have the acromion process, you have the coracoid process here, and there's a ligament between the two processes, coracoclavicular ligament. And you have these muscles and ligaments all around, protecting the joint, stabilizing. You call it stabilization. Okay, stabilizing the joint. But you can see on the inferior side, there is not much reinforcement to stabilize it. So when the shoulder dislocates, it dislocates in that direction. If the head is there, it dislocates in that direction, which is called inferior dislocation. Later it will be pulled up. That's a different issue. Okay, so I can't tell too many things. You might get mixed up. Okay. Then when it comes to fractures of the scapula, I'm not going to discuss all the fractures here, but anyway, I will just mention a few things about the scapular fractures. Now, I said the clavicular fractures are the commonest fractures in the body, but the scapular fractures are very uncommon. Now, what is the reason? Now, the clavicle, if you want, you can feel your clavicle here. Okay, at the root of the neck, clavicle is throughout. You can feel it because it's exposed. Okay, only the underside you cannot feel, and the posterior surface, so anterior surface and the superior surface, and the lateral and medial ends, all you can feel outside. So that is one reason why it gets fractured so commonly. But on the other hand, in contrast, scapula is covered all around with muscles. Only in few places you can touch it, so it's well protected. So unless, so if you fall on the outstretched hand, scapula will not break for sure. Okay, but road traffic accidents, a hard blow to the scapula when a person is assaulted, then you can get fractures of the scapula. Otherwise, it's not very common fracture. Okay, so that's the point I wanted to raise. So we'll take a look at this video now.
This is right scapula, superior, inferior, lateral, and medial sides. This is the anterior surface of the scapula. This is the lateral border. This is the medial or the vertebral border. And this is the superior border. Inferior angle, superior angle, and the lateral angle. On the anterior surface, this area is called subscapular fossa. Subscapularis muscle is attached to the subscapular fossa. Here you can see scapular notch. This is coracoid process of scapula. At the lateral angle, this is glenoid cavity or glenoid fossa. And this is acromion, behind the glenoid fossa or posterior to the glenoid fossa. An important ligament called coracoclavicular ligament is attached to the coracoid process. There are several other structures that are attached to the coracoid process, which we will discuss later. Now I will turn this to the posterior surface. On the posterior surface, you can identify the spine of the scapula. The spine ends at its lateral end at the acromion. On the posterior surface, above the spine lies the supraspinous fossa, and below it lies the infraspinous fossa. Supraspinatus muscle is attached to the supraspinous fossa, and infraspinatus muscle is attached to the infraspinous fossa here. This is right scapula, and this is right clavicle. Now we will articulate them together. They are articulated at the acromioclavicular joint here. And now remember, when you articulate them, to leave a reasonable gap between the two bones here, so that the structures from the root of the neck can pass into the upper limb and the thorax.
Okay, then the humerus. Now, humerus is the bone, the only bone in the arm or upper arm. Some people call it upper arm. Then, if you look at the humerus, the proximal end, you can see head here. It's not a complete head. Anyway, you know, you have the head there, and you have two necks. One is called anatomical neck and the other one is called surgical neck. Now, this anatomical neck, if you look at the anatomical neck here, this is where the joint capsule is there, attached between the anatomical neck here and the rim of the glenoid cavity. Now you have the glenoid cavity, then the capsule is attached to the anatomical neck here. Only thing is, in this area, in the inferior side or the medial side, the attachment goes a little bit lower down here and up to the surgical neck, like then it comes back to the anatomical neck. Now, the anatomical neck is actually the true neck of the humerus. Then you have another neck called surgical neck. Now, the surgical neck is a clinical concern because there are structures related to the surgical neck. Certain injuries can damage these structures, and the other thing is you can have fractures at the surgical neck, and these fractures are the ones that damage the structures related to the surgical neck. And these structures that are related to the surgical neck, again, you will learn later when you do the regional anatomy. The two important structures are the axillary nerve and the posterior circumflex humeral artery. So these two are related like this. Now this is the humerus head and the posterior surface of the neck here. So you see the axillary nerve and the posterior circumflex humeral artery related there. So if there's a fracture here, these can get damaged. And even without a fracture, if this joint dislocates, then these structures will be pulled down by the bone, and then again they can break. It's mainly the important one, most important one is the axillary nerve. I don't know whether you can remember these things that way, but we'll see. Then other parts in the proximal end. So we already mentioned about the head and the anatomical neck here. Then you have these two tuberosities or tubercles. Both can be used, tubercle or tuberosity. This is the anterior view here. This is the anterior view. Therefore, this is left humerus. Okay. So you have a lesser tubercle or tuberosity in front and a greater tubercle behind. This is greater tubercle behind. Greater tuberosity behind. Lesser tuberosity in front and greater tuberosity behind. Then in between the two tuberosities, there is what is called intertubercular groove. Intertubercular groove. Sometimes it is called bicipital groove. Bicipital groove, because there is a muscle called biceps brachii. The long tendon of biceps passes through this groove. That's why it's called bicipital groove. Okay, because the biceps tendon passes through it. Okay, so you can call it either way. Then the other thing is the two tuberosities continue, the ridge-like thing continues down for some distance, which is called the crest. It is called the crest of the tubercles. You can say crest of the greater tubercle and the crest of the lesser tubercle or tuberosity. Okay. So then if you go further down, further laterally, anterolaterally, you get a raised area here, which is called deltoid tuberosity, and this is the point at which the very strong muscle is here, the shoulder muscle, which is called the deltoid muscle. You know the deltoid muscle that is attached to the deltoid tuberosity. Then in relation to the deltoid tuberosity, actually below the deltoid tuberosity, in that area, you get what is called radial groove on the posterior surface. Radial groove on the posterior surface. Why it is called radial groove? Because the radial nerve passes through it, and there's another blood vessel passes through it. Okay, so if there's a fracture through the radial groove in the shaft, radial nerve can get in the radial groove. Radial nerve can get damaged again there. Okay, these things you will learn later. Then the distal end of the humerus, distal limb, there are several structures. I will only show you the main structures. On the medial side, you have a medial epicondyle. Laterally, you have a lateral epicondyle. Don't use these as identification features when it comes to identifying the side of the bone. Okay, because you cannot remember that lateral epicondyle is exactly like this and the medial epicondyle is exactly like that. Okay, so but rather you go by the other structures that you can really identify. Okay, anyway, you have the medial and lateral epicondyles. Above the epicondyles, you get what are called supracondylar ridges. supracondylar ridges, lateral and medial supracondylar ridges. Then in the posterior view, you can see this olecranon fossa, which will guide you to say that, okay, this is the distal end of the humerus. Okay. And the olecranon process of the ulna articulates with the olecranon fossa. Then the posterior side, you see this trochlea, which you see on the anterior side as well, trochlea, which lies towards the medial, just lateral to the medial epicondyle. Then further laterally, you get what is called capitulum, a rounded tubercle-like thing, which you cannot see in the posterior view here, which you cannot see on the posterior view here. Capitulum is on the anterior side there. Okay. Then above the capitulum and trochlea, you get a radial fossa above the capitulum and a coronoid fossa above the trochlea. Because the trochlea articulates with the ulna here. Trochlea articulates with the trochlear notch on the ulna, and the capitulum articulates with the head of the radius. So during extreme flexion, the two fossae, the coronoid fossa, gives it accommodates actually the coronoid process of ulna, because the process comes to lie there. Okay. Then during extreme flexion, the radial fossa accommodates the radial head, because that moves into that direction. You will understand that if you have the bones, if you flex the bones together, you will understand this point. Okay, I'll run the video again.
This is right humerus, medial side, lateral side, distal and proximal. This is the anterior surface of the humerus. Now we will take a close look at the proximal end of the humerus. At the proximal end, this part is called the head. This is the part that articulates with the glenoid cavity. Here is the anatomical neck, and here is the surgical neck. You can identify the anteriorly lying lesser tubercle and the posteriorly lying greater tubercle. Between the two tubercles, you should be able to identify the intertubercular groove here. On the anterolateral surface, you can identify the deltoid tuberosity on the shaft. And the posterior side, in that oblique direction, you can identify the radial groove. The radial nerve and the deep artery of the arm are related to the radial groove here. Now we will take a look at the distal end of the humerus. This is the medial epicondyle. This is the lateral epicondyle. This is the lateral supracondylar ridge, and this is the medial supracondylar ridge. This is trochlea lying medially, and this is capitulum lying laterally. Capitulum articulates with the head of the radius, and the trochlea articulates with the trochlear notch on the ulna. This is above the capitulum lies the radial fossa, and above the trochlea lies the coronoid fossa. During extreme flexion, the radial fossa accommodates the head of the radius, and the coronoid fossa accommodates the coronoid process of ulna. If I turn it to the posterior side, this is called olecranon fossa. The olecranon of the ulna articulates with the olecranon fossa. This is right humerus and right scapula. The glenoid cavity of the scapula with the head of the humerus forms the glenohumeral joint, which is also called the shoulder joint. It is a very mobile joint with flexion and extension, abduction and adduction, with circumduction and medial and lateral rotation possible.
Okay, now we will study the forearm bones. First, there are two forearm bones, ulna and radius. Ulna lies medially and radius lies laterally, you know that. Now, if you look at the proximal end of ulna, this is the olecranon. This is the olecranon, process of olecranon. And this, on the anterior surface of olecranon, you get the trochlear notch that articulates with the trochlea on the humerus. Then this is actually coronoid process of ulna, and this area is the tuberosity of the ulna. Tuberosity of ulna. There are muscles attached to the tuberosity of ulna. Then this is on the medial side, on the lateral side of the bone. You get this radial notch. This is called radial notch. The head of the radius articulates with the radial notch there. Then the head of the radius articulates here. Then this joint here is a pivot joint, which is called proximal radio-ulnar joint. It's proximal radio-ulnar joint. We'll come back to it anyway later. Then the proximal end of the radius, on the other hand, has a head there. Now this one, you don't call this head. Okay, so this is called proximal end of ulna. Head is distal. Now, in contrast, the radius has the head proximally, and then there is a neck, and immediately distal to the neck, you get the radial tuberosity. Now, ulna had ulnar tuberosity here, ulnar tuberosity. Radius has radial tuberosity. Again, you know, muscles are attached to the radial tuberosity there. Then there is another point here, when the head of the radius articulates with the radial notch on the ulna, it is kept in place by a ligament called annular ligament, which is a ligament encircling the head of the radius, kept in place. Then there's another point, when the elbow joint is formed here, and the proximal radio-ulnar joint is here now, they are very close to each other. The synovial membrane of the elbow joint continues into the proximal radio-ulnar joint. So they have a common synovial membrane. So therefore, there is a connection between the two synovial joints. The fluid from here can go into this one. Okay. So rather than the capsule, it is the synovial membrane that continues under the annular ligament. Okay. Capsule is actually attached to the annular ligament above it. Okay. Even though they have drawn it like that. Then the elbow joint can be considered as in two parts. That is the humero-ulnar joint between the humerus and the ulna, that is the trochlea of the humerus and the trochlear notch on the ulna, and behind you have the olecranon on the ulna and the olecranon fossa of the humerus. That is humero-ulnar joint. Then the other one is the humero-radial joint. So that is the capitulum of the humerus articulates with the head of the radius. Okay, so that is called humero-radial joint. So this is a synovial hinge type of a joint. Then the distal ends of the two bones, at the distal ends, there is an important landmark, which is called the styloid process. That is radial styloid process, which lies laterally. You can actually feel it on your body. If you have the hand like this, you can feel the radial styloid on the lateral side. But the ulnar styloid is only felt posteriorly rather than medially. It's here. You can feel the ulnar styloid more or less, posteriorly. Okay, and then there is another joint here which is called distal radio-ulnar joint here. Now, if you look at that end of the radius, you have what is called ulnar notch there. Now, the ulna in the proximal end had a radial notch articulated with the head of the radius. Here, the radius in the distal end has an ulnar notch that articulates with the head of the ulna. This is the head of the ulnar bone. Okay, so there is an articulation which is called distal radio-ulnar joint. Here, it is the both proximal and distal radio-ulnar joints. They are pivot synovial joints. Okay, and the wrist joint is formed here actually with the two proximal row bones in the carpus, scaphoid and lunate bones. So the distal end of the head of the ulna is not involved in the formation of the wrist joint. So this is the wrist joint. It is also called radiocarpal joint, which is very specific name, which actually shows you between which bones the joint is. Actually, the radiocarpal means it's between the radius and the carpal bones rather than the ulna. So what has happened is that there is a disc. I mean, this is rather than an articular disc, it's a fibrocartilage disc. Because there is no joint there, but the articular, the cartilage disc does is that it prevents the ulnar bone getting involved in the wrist joint. Okay, so it's excluded from the wrist joint. So the joint is between the distal end of the radius and the mainly it's the scaphoid and the lunate that articulates with the radius. And during there are movements called pronation and supination. Pronation and supination, I'll come back to it. During pronation and supination, there is rotation of the radius around the ulna. So it rotates this way and that way. So when that rotation takes place, since the ulna is not involved in the joint and the movement takes place here, it's not involved in the wrist joint, I mean, this whole thing, except ulna, this whole thing, with the hand, the radius moves. It rotates around the ulna in the center. Okay, so you will appreciate that when you learn it. Okay. Then the interosseous membrane, we said we used it as an example for a fibrous joint. So this is the interosseous membrane between the medial border of the radius and the lateral border of the ulna. Now, if you look at the direction of fibers, this is the direction of fibers. Can you see direction of fibers between the two bones? Now, this direction of fibers is important because now since only the radius, distal end of the radius is involved in the formation of the wrist joint, if there are forces transmitted from the hand into the radius, like in falling in the on the outstretched hand, like what happens is it's always advantageous for both bones to take the forces. So what happens is, because of this arrangement of the interosseous membrane, the direction of the membrane fibers, this forces transmitted through the radius, if the radius tries to move proximally in relation to the ulna, then these ligaments will, the interosseous membrane will get pulled towards the radius side, and then the forces will be transmitted through the ulna as well. Okay, for that reason, it is arranged that direction. So this is pronation and supination of the forearm. If you remember your anatomical position, in the anatomical position, actually the forearm is supinated. That's why the palm is facing forwards in the anatomical position. So from that position, if you pronate, then the palm that was facing anteriorly will now face posteriorly. That is the pronated position. So when that happens, what happens is the radius with the thumb, now from the supinated position, thumb is lateral. Then in the pronated position, thumb is now on the medial side. So as the distal end of the radius. Okay, initially it was on the medial side, now it is on the lateral side. Ulna is here, now ulna is there. Okay, ulna does not move, it is the radius that moves this way and that way. So this is shown by this diagram actually. Now this is the supinated position, the anatomical position. Now this is the pronated position, where now the radius has crossed ulna. So they are crossed like X. Initially they were parallel. Here they were parallel to each other. Now if you look at the axis of this pronation and supination, actually the axis passes obliquely from the center of the head of the radius, and the other point is the base of the ulnar styloid. You remember the ulnar styloid? The styloid process here, ulnar styloid. So then that around that axis, this will rotate this way and that way. There is slight movement of ulna during this process, but it doesn't rotate as such. Okay, it's kept without rotation. Okay, now we'll look at this video.
This is right radius and ulna articulated together. Lateral side, medial side, distal, and proximal. These are the anterior surfaces of the two bones. If you take a closer look at the proximal end of the two bones, here is the olecranon process of ulna. This is trochlear notch. And this is coronoid process of ulna. This is coronoid process. And this is the tuberosity of ulnar bone. And here is the radial notch on the ulna that articulates with the head of the radius. This is the head of the radius. And this is the neck of the radius. Here is the radial tuberosity. And these are called interosseous borders of the two bones. The interosseous membrane is attached to the interosseous borders. This is the distal end of the two bones. This is the radial styloid, and behind is the ulnar styloid here. This surface at the distal end of the radius is to form the wrist joint. This is the head of the ulna. There is an articular disc here, which is a fibrocartilage disc that separates the head of the ulna from the wrist joint. The joint here is the distal radio-ulnar joint. Both the distal radio-ulnar joint and the proximal radio-ulnar joint are pivot joints, and they are synovial joints.
Okay, then carpus. Now, carpus of the hand. Yeah, so before that, if you go in general into the hand, so carpus is only part of the hand. Okay, so the most proximal end is called the carpus. Then you have the metacarpal bones. Then you have the phalanges, proximal phalanx, intermediate phalanx or middle phalanx, and the distal phalanx. Then you have intercarpal joints here. This area you get intercarpal joints. Then you have carpo-metacarpal joints. Then you have metacarpophalangeal joints, and then the interphalangeal joints. You have 2 phalanges in the thumb. Then other fingers, you have 3 phalanges each. Altogether, there are 14 phalanges. Then if you look at the carpus, I said there are 8 carpal bones. There are 2 rows. In each row, there are 4 bones. So if you look at the proximal row from lateral to medial, it is scaphoid, that is scaphoid, lunate, tripectrum, and pisiform. Then the distal row of bones, trapezium, trapezoid, capitate, and hamate. Those are the 8 carpal bones. And then these carpal bones, lunate and scaphoid, they are involved with the distal end of the radius to form the wrist joint. This will not be involved in the wrist joint formation. So there is a disc covering it here. So this intercarpal and carpo-metacarpal joints, if you remember, they are plain synovial joints. So gliding movements are possible in these joints. Then if you look at the distal end of the radius, distally, this is how you see the face of the radius and the ulna. You can see the radial styloid here and the ulnar styloid more towards the posterior side. There's another structure that we didn't mention before, this dorsal tubercle of the radius, which is an important landmark actually, again, which you can feel. If you have the posterior side here, if you feel the radius posteriorly here, I don't know whether you can see, you can actually feel the tubercle there. It's very easily felt. That is also called Lister's tubercle. Okay, dorsal tubercle of the radius. There are tendons related to it. Okay, there's a tendon actually passing like this through it. Okay, taking an angle there. Okay, it acts as a pulley there. So that's a different reason. Then Then this is this fibrocartilage disc that prevents the head of the ulna getting involved in the wrist joint formation. It is attached to the, you can see this is the ulnar styloid. It is attached to the base of the ulnar styloid on one side, and the other side it is attached to the distal end of the ulnar notch on the radius. Distal end of the ulnar notch on the radius, covering this area. Then this is the wrist joint. These are the areas for the lunate and scaphoid. Lunate and scaphoid, but with the movement, these things can change here and there. You can do abduction and adduction, then these things will move. Okay, now we'll go through this video as well.
This is the right hand. These are carpal bones. There are 8 carpal bones. In the first row, there are 4 carpal bones: scaphoid, lunate, triquetrum, and pisiform. In the distal row, there are 4 carpal bones again: trapezium, trapezoid, capitate, and hamate. Identify the tuberosity on the scaphoid.
Better to call it tubercle.
Ridge of the trapezium and the hook of the hamate. The wrist joint is formed between the distal end of the radius and the scaphoid and lunate bones. Head of the ulna is not involved in the wrist joint. There are 5 metacarpal bones. These are carpo-metacarpal joints, and these are intercarpal joints. The first finger has 2 phalanges, proximal and distal phalanx. Other fingers have 3 phalanges each: proximal phalanx, middle phalanx, and distal phalanx. The joint between the metacarpal bone and the proximal phalanx is called metacarpophalangeal joints. And the joints between phalanges are called interphalangeal joints.